Hello guys, welcome to Global Perfusion Community. So we have Mr. Emmanuel here and he is going to share his insights and knowledge on a wonderful topic, and we'll have a wonderful session tonight. It's I think in some countries it's evening, somewhere it's night and maybe afternoon. So we are live all over the globe and our viewers are watching us from different parts of the globe. So we welcome you all in the Global Perfusion Community. So, the topic for today's session is perfusion strategy in pediatric heart surgery. So, Mr. Emmanuel is going to present his topic to all the perfusion community, and he's going to share his knowledge, his experience in pediatrics. So, I welcome Mr. Emmanuel.
Thank you. Yeah, thank you so much.
Yeah.
Thank you. It's an honor to be here today. My name is Emmanuel Odhiambo Mbaka, and I'm a perfusionist here in Kenya. And today I want to share about perfusion strategy in pediatric heart surgery. You'll understand that when dealing with pediatric, it's quite different with adult cases, and so it's important for us as perfusionists to understand when dealing with pediatrics, that some different things that we need to understand. And today I'm going to share about the perfusion strategy used in pediatric heart surgery. Next slide. So our goal in this presentation is we need to understand at the end of the presentation, we need to understand to be able to deliver safe and effective cardiopulmonary bypass support for children while minimizing complications such as systemic inflammatory mediators, organ injury, and neurodevelopmental issues. Next slide. So let me just go through the objective that we'll have in this presentation. So we're going to talk about lesion and physiology. We're going to talk about size, age, and metabolic supports. It's very important. We'll talk about circuit minimization. We'll talk about prime composition and hematocrit strategy. We talk about myocardial protection tailored to pediatric myocardium, brain and end organ protection. We'll talk about systemic inflammatory mediators, and last but not least, we'll talk about hemostasis. Next slide. So let's start by talking about lesion and physiology. Why is it important as a perfusionist to understand the lesion the patient is having and the physiology behind? So it's very critical because congenital heart defects create a very different circulatory patterns compared to normal hearts and adult acquired disease. So unlike adults, pediatric patients often come to surgery with shunts, abnormal pressures, and altered oxygenation patterns. So you cannot apply one size fits all perfusion plan. So every pediatric perfusion strategy begins with understanding. You need to understand what the patient's circulations look like pre-operatively. So you need to understand where is the blood mixing, what pressures and flows exist in systemic and pulmonary circuits. Also, you need to understand how does that affect oxygen delivery and organ perfusion during CPB. And by understanding all this, you'll be able to choose your cannulation well. By understanding the right approach of cannulation, you'll also understand the flow targets, venous drainage management, and myocardial and cerebral protection strategy. So the lesions that we'll talk about, just to mention, like tetralogy of Fallot, you need to understand that it's a synotic lesion with RVOT obstruction and VSD. Also, the transposition of great arteries. These patients, they have ASD, they have VSD, they have PDA. So interruption during CPB can cause severe desaturation if venous return is not well controlled. For the patients who have hypoplastic left heart syndrome, systemic perfusion depends on PDA and retrograde arch flow. So you find that when we are working on these patients, you might need to use antegrade cerebral perfusion. And then atrioventricular septal defects, you understand there'll be a shunt. So the left to right shunt, which leads to high pulmonary blood flow pre-op. So there's risk of pulmonary overperfusion during CPB if not well controlled. Next slide. So let's talk about size, age, and metabolic index support. So size, age, and metabolic index support is one of the most critical concepts in pediatric CPB because children are not like adults. So their physiology requires flow rates, oxygen delivery, and perfusion strategies scaled not only to body size but also to the metabolic demand and developmental stage. So let us ask ourselves. A 3 kg neonate, just an example, a 3 kg neonate and a 30 kg child cannot be perfused at the same absolute flow or even the same index flow without accounting for metabolic rate. So the neonates have 2 to 3 times higher oxygen consumption per kg than adults. So the key things that I can talk about that are involved in the size, age, and metabolic index support include the flow requirements, oxygen delivery targets, and metabolic demand. Next slide. So the neonates have high metabolic rates, that is high oxygen per kg. Also, they have high immature myocardium, which leads to poor tolerance of ischemia and calcium fluctuations. Also, they have immature autoregulations. Now, this means their brain is vulnerable to flow and pressure. Next slide. So the flow requirements, we need to understand the flow is expressed as cardiac index, that is mils per kg or liters per minute per meter square. So the flow requirement is very important, and we need not to use the adult flows to the neonates or to the neonates or children, because it will lead to underperfusion and organ injury. So the neonates and small infants, you find that their baseline metabolic rate is high, and so they need high flows per kg. So you'll find when we are working on the neonates, you find us we do 150 to around 200 mils per kg per minute. That's maybe a cardiac index above 2.4 to around 3 liters per minute per meter square. And then for the older children, you find their metabolic rate decreases. Find their flows range between 80 to 120 mils per kg. So that you find their index come to around 2.0 to 2.4. Next slide. So let's talk about oxygen delivery targets. So there's a formula there of delivery of oxygen. So there's pump flow times arterial oxygen, and then into bracket there is HB, there's saturation, there's oxygen saturation. At the 1.36 is always a constant number plus the dissolved oxygen. So you need to maintain your DO2 index above 280 to 300 mils per minute per meter square during normothermia. By doing this, you'll find that your patient will be well perfused and organs will be well perfused. Next slide. So let's talk about the metabolic rate. So neonates' oxygen consumption is 6 to 8 mils per kg per minute. For adults, oxygen consumption is 2 to 3 mils per kg per minute. This explains why neonates need higher index flows, even when you are cooling them. Next slide. So let's talk about circuit miniaturization. So it's very important in pediatric CPB to reduce the size and the priming volume of the extracorporeal circuit to match the small blood volume and fragile physiology of the infants and neonates. Large, high-volume circuit can cause hemodilution, can cause low hematocrits, and increased transfusion needs, an inflammatory response which will worsen postoperative outcomes. So the key components of circuit miniaturization, you as a perfusionist, you need to work on your tubing. So you need to have shorter tubings. So short arterial and venous lines, which will reduce volume and resistance. And also you need to keep the oxygenator and reservoir as close to the patient as possible. That means you need to bring the near your oxygenator and the reservoir near to the surgical field. Also, you need to avoid unnecessary loops in the venous and arterial lines. Next slide. Also, you need to have your tubings need to have smaller diameter tubing on the AV loops. So, using the AV loops, you find the neonates there is 316 and a quarter. You'll find the infants you use a quarter, and children you use 38 and a quarter. So this will help you to minimize the priming volume, which will lead to hemodilution in case you're using the adult AV loops. Next slide. Before I mention, one thing you need to understand: when you use too large tubes, there will be unnecessary volume and poor venous drainage without vacuum. And when you use too small two small tubings, there will be increased resistance and risk of line shatter. So that you need to have to put that in mind as a perfusionist. So also let's talk about miniature oxygenators and filters. So you need to use pediatric oxygenator which have low prime, for example, 40 to 80 mils, and also you need to have small reservoir. So use hard shell reservoir with low minimum operating volume. Next slide. So let's talk about prime composition and hematocrit strategy. So prime composition and hematocrit strategy, it's very critical elements in pediatric CPB because of the small circulating blood volume of neonates and infants. So unlike adults, even modest prime volume can dramatically dilute the patient's hematocrit, leading to inadequate oxygen delivery and increased risk of organ injury. So let's ask ourselves why prime composition matters. So pediatric patients have low circulating blood volumes. So you'll find that, example, a neonate who is 3 kg, the blood volume is between 250 to 300 mils. An infant, example, who is 10 kg, the blood volume is around 700 to 800 mils. So this CPB prime volume, even when miniaturized, may equally or exceed patient blood volume, leading to hemodilation. So you'll find this patient, when, for example, they have a hematocrit of 40, when you do your calculation post-hematocrit, post-CPB hematocrit, you'll find it has dropped to 15%. And if there's no strategy that is applied, you might find there is increased risk of cerebral hypoxia. Next slide. So let's talk about the components of the prime. So a crystalloid-based solution will be used. So typically balanced electrolyte solution. So there are centers, they'll use plasmalite, which is a good solution. Also normal salt ringers or ringers lactate, which is widely used. But you need to avoid normal saline because of hypochloremic acidosis. Also, the volume for the neonates depends on the circuit. Usually we use between 100 to 250 mils for neonates, and also you need to add the additives. So you need to add things like heparin, which is a standard anticoagulation. So around 3,000 to 4,000 units in prime. Or you need to add sodium bicarbonate, which used to buffer metabolic acidosis from priming and cooling. Also, you need to use mannitol. The use of mannitol is to promote osmotic diuresis and reduce edema. And in case you're using blood prime, you need to add calcium, which you remember the citrate in that blood. So calcium will bind citrate. Next slide. Another component in the priming is colloids. So the colloids that we use is albumin, and albumin maintains oncotic pressures and reduce interstitial edema. Often added in for the neonates, it's around 25 to 50 mils in prime. The blood components that we'll use are packed RBCs and also fresh frozen plasma. Next slide. So let's talk about the strategy you as a perfusionist used to use to achieve your target hematocrit. So there is blood priming. So you need to mix the packed RBCs with the crystalloid and add additives, the one that we mentioned earlier, to achieve the desired hematocrit before initiation of bypass. Also, another thing you have to use is use retrograde analogous priming. It's called RAP. Before CPB starts. Now, this one displaces crystalloid prime with the patient blood to minimize dilution. Another component that you can use is modified lateral filtration. This is done after the CPB, and it's used to remove excess water and increased post-bypass hematocrit. Next slide. Now let's talk about myocardial protection in pediatric myocardium. So it's very important because myocardial protection in pediatric patients requires special consideration because the pediatric myocardium, especially in neonates and infants, is structurally and metabolically different from the adult heart. These differences influence cardioplegia strategy, dosing, temperature management, and ischemic tolerance. So let's ask ourselves, what are these unique features of pediatric myocardium? So number one, these pediatric myocardium, they have high water content. They are prone to edema during ischemia and reperfusion. Also, they have immature sarcoplastic reticulum. This leads to limiting calcium handling ability, and it depends mostly on extracellular calcium. Also, these myocardiums, they have high metabolic rates. Also, these myocardium, they have lower compliance and higher diastolic stiffness, and they are more sensitive They're more sensitive to volume and pressure changes. Also, they have less developed coronary collaterals network, and this leads to higher risk of ischemic injury if cardioplasia delivery is inadequate. Next slide. So, what are goals of pediatric myocardial protection? So, the goals include the following: the rapid and complete diastolic arrest, avoid calcium overload during reperfusion, avoid adequate energy stores, prevent edema formation, and also facilitate safe reperfusion after ischemic injury. Next slide. So, what cardioplasia do we use? In our centers, we use the needle cardioplasia because it's popular in pediatrics and congenital surgery. So, and then you find the duration of the needle is around 60 to 90 minutes of protection per dose. Next slide. So there's special consideration by the lesion. So as a perfusionist, you need to understand the lesion the patient is having. Also, it will help you when also you're giving your cardioplasia. So for the cyanotic patient, those with tetralogy of Fallot, often they have hypertrophied ventricles. This means they require more cardioplasia volume for uniform cooling. Also, these with single ventricle physiology, like hypoplastic left heart syndrome, they need extra care during reperfusion to avoid volume overload. And those patients who have long ischemic times, for example, those one with we are working on, they have complex arch repair. You need to consider continuous cardioplasia drip or intermittent perfusion. Next slide. So let's talk about brain and end organ protection. So it's very important to understand that the brain and end organ protection in pediatric CPB is critical because children, especially units and infants, have immature autoregulatory system. They have high metabolic demands and small functional reserves. A structured protection bundle approach ensures multi-organ preservation during and after the CPB. So let's ask ourselves, why is the protection critical to pediatrics? So their brain, they have high oxygen consumption, that is 40 to 50 of total body oxygen in units. So also they have immature blood-brain barrier with risk of emboli and hypoperfusion. Their kidneys, they have small renal reserve, which is vulnerable to low perfusion pressures and hemolysis. And their liver, liver, which is essential for metabolism and coagulation factor synthesis, they are affected by low flow and hypoxia. Next slide. So, things that you need to consider are the intra-bypass strategies. So, some of the intra-bypass strategies that you need to put in place, you need to ensure there's good cerebral perfusion. So, how do you do that? So, you as a perfusionist, you need to maintain good flow rates. So, as a perfusionist, you need to, for units, as we said earlier, have your flows at 150 to 200 ml per kg per minute. This because they have high metabolic demand. Another thing you need to consider is good perfusion pressure. So you need to maintain your maps between 40 to 50 in units, millimeter mercury, and 50 to 60 in the millimeter mercury for the older children. Also, you need to work on your proper temperature management. So you need to understand the hypothermia. Hypothermia decreases metabolic demand. So mild hypothermia, that is between 32 to 34 for the low-risk cases. Also, there's moderate hypothermia, that is between 28 to 32 for complex repairs. And also, we have the deep hypothermia, which is from 18 to around 22 degrees Celsius for circulatory arrest. Also, you need to have selective cerebral perfusion when the surgery involves the arch. And also, you need to use NIAS, which helps to monitor cerebral saturation. Next slide. Also, there's oxygenation and carbon dioxide management. So you need to maintain your partial oxygen between 100 to 150 millimeter mercury and avoid as much as possible hyperoxia. Also, you need to know how to maintain, to work on your pH, your blood gas. So there is alpha stat and the pH stat. So the pH stat is used during cooling for better cerebral homogeneity, and the alpha stat during rewarming, which preserves autoregulation. Next slide. So also you need to have the hematocrit strategy. So you need to maintain high hematocrit during cooling for cerebral protection and avoid as much as possible excessive hemodilation. Also, one thing you need to, for these units and and infants, you need to avoid completely hypoglycemia and severe hyperglycemia. Next slide. So the post-CPB strategy that you use to work on your hematocrit is to do the modified ultrafiltration. This reduces the total body water and cytokines and also improve your hematocrit. Next slide. Now let's talk about systemic inflammatory mediators. As a perfusionist, the core aim to reduce the systemic inflammatory mediators is to reduce the triggers, number one. You need also to shorten exposure, that's number two, and also to actively remove mediators. So things that drive to systemic inflammatory mediators in pediatric CPB include the following. There's blood to artificial surface contact. This activates the complement, neutrophils, and coagulation, leading to cytokine surge. Also, there's ischemia and reperfusion. So reactive oxygen species are also known as ROS, burst, and there's endothelial injury and capillary leak. Also, there's hemodilation and transfusion. This lowers oncotic pressure, adds storage lesion byproducts, and also there's hypothermia and rewarming. So you'll find that temperature swings amplify inflammatory signaling. Also, there is sanction and cardiotomy blood. This lipid microemboli activate mediators. Next slide. So let's ask ourselves, how do you prevent the inflammatory mediators? There are ways you need to. There's a ways we do to minimize and to prevent inflammatory mediators. So number one is to minimize your circuit. So you need to shorten your lines. Also, low prime oxygenator stroke reservoir. Also, you need smallest practical tubing. Another thing that you can do is biocompatibility. So this is whereby you need to use heparin-coated circuits. That is where it's applicable. Some centers, they might not be having that one. And also, you need to use hemofiltration. That whereby we use the CAF, conventional ultrafiltration, and modified ultrafiltration, and also pharmacology. So some centers you'll find they're using steroids to prevent the inflammatory mediators. Next slide. So let's talk about hemostasis. So you as a perfusionist, you need to understand that during surgery, your goal is to preserve patient's blood. You need to minimize allogenic transfusion and maintain effective clot formation without excessive bleeding or thrombosis. So why hemostasis is critical in pediatrics, these children, they have a small blood volume. Even minor blood loss cause significant anemia and hemodynamic instability. So also there is dilutional coagulopathy, which is characterized by a large prime volume relative to patient size, dilutes, clotting factors, and platelets. And also there is immature coagulation system, especially in units, leading to reduced thrombin generation, lower fibrinogen, and less reserve. Also there's repeated transfusion, which leads to increased inflammatory response, TRALI, infection risk, and cost. Next slide. So let's talk about factors affecting hemostasis on CPB. Number one is hemodilation, which leads to lower hematocrits, platelets, and clotting factors. We have also hypothermia, which leads to slowed enzymatic reaction in coagulation cascade. Also, we have heparin anticoagulation. You remember, heparin is essential for CPB, but it prolongs clotting. Also, there's platelet dysfunction from direct blood contact with the circuit and hypothermia. Also, there's inflammation and complement activation, which worsen platelets activation and consumption. And also, prolonged bypass time leads to greater exposure and consumption of the clotting components. Next slide. So let's talk about the hemostasis management strategy. So there's pre-bypass preparation. So there's use of antifibrinolytic. So you'll find these patients are given tranexamic pre-op. So they're given tranexamic pre-op. Also, there's baseline labs. So you need to check their APTT, their INR, their platelets, and also blood conservation plan. So you need to have a plan. So you can consider autologous techniques in your blood conservation plan. Also the circuit preparation. So by circuit preparation, you find we need to use blood frame, which will help. the use of blood prime, and also minimize also crystalloid prime by use of either RAP, that is retrograde autologous priming, or VAP. Thank you. Next slide. So on the pump preparation, you as a perfusionist, you need to monitor your ACT. So maintain therapeutic anticoagulation. So often use our ACT needs to be above 480 seconds for CPB. And also you need to avoid excessive heparin. So avoid excessive heparin. Remember, the dose is based on the weight and heparin concentration, not only by the ACT. Also, there's platelets preservation. So you need to limit your suckers use. So try as much as possible to not to have high suckers. For example, if, making your rollers to be around 1 liter, at least have your rollers around 300 or 400. It will help in platelets preservation. Also, there's hemofiltration, that is using of conventional ultrafiltration and also modified ultrafiltration at the end of the surgery. And also there's temperature management. You need to avoid very deep hypothermia unless it is required for circulatory arrest, because it preserves coagulation enzyme activity. Next slide. So preparation when separation from the CPB, remember we have talked about modified ultrafiltration, and also you need to reversal of heparin with the protamine at the right dosage, and also you need to check your labs immediately after separation. And the labs that we check include the ACT, and also you need to check your hematocrit to see where you are after the surgery. Next slide. Yeah, I think I'm done with my presentation. Thank you so much, and I welcome the question. Thank you. Thank you.
Okay, so it was a wonderful presentation,
Thank you.
I hope all of you have gained a lot of knowledge from this session. So now we are going to have the live Q&A session. So guys, you can comment your questions in the live comment section, and we'll pick the questions, and Mr. Emmanuel will answer and explain your about his strategies. So we have a question over here.
Okay.
So I think Emmanuel can read the question, I guess.
So the question is about the anticoagulant dosage before going on CPB. So for us, we use 400 international unit per kg. That is the heparin dosage that we give to the patient before we proceed to continue with the surgery. Yeah.
Okay, we have one more question.
So when you shorten the circuit line in pediatric case and pump failures occurs, what techniques and strategy will you use to switch to a new pump? I'll repeat the question. When you shortage the circuit line in pediatric case and pump failure occurs, what techniques and strategy will you use to switch to a new pump? Wow, this question, it's an interesting question.
Yeah, I think it's a nightmare for all the perfusionists.
So it has never happened to me. It has never happened. I don't know if you, Paul, it has happened to you. But when I'm preparing for a case, there's some things that I need to put in consideration. And number one, it's my line, the circuit linings, and also, if I have worked well in my preparation, I don't know it will happen in when the case is going on. Though it can happen, but remember we have the in case in case of the pump failure, there's a way we are going to work on that by use of the crank, right? In case the pump fails to function. But I have never come across where it has failed because of the circuit line is short. Yeah, but I think your preparation before, as you're preparing, you need to have a considerate length of your lines. That I think that's what I can say. I don't know what.
Yeah, we should be prepared for the like all the complications. We should keep a standby pump ready. We should keep
Okay.
oxygenator ready. Everything should be prepared because we never know, anything can go wrong.
Yeah.
So we should be prepared. And I wish this won't happen with anyone.
Yeah, this it has never, and I always pray it doesn't happen to me. I always pray. I always pray. Yeah.
Okay, so thank you, Priti and Prasyato. So thank you for your questions. We'll go to the next question. I hope you can see the question.
Yeah, the drugs usage and their dosage during CPB. So I'll start with the drugs that we use during CPB, and there is sodium bicarbonate. That's when you are correcting the acidosis. You find that your base excess is negative and you want to correct it. So there's a formula that we use where there's base excess. You multiplied it is base excess times weight times 0.3, and then you divide by 2. So you have this, if I'm hoping I'm correct. So you find there's half correction and there's full correction. Okay, so that's number one we use. And also there's mannitol, and mannitol is 0.5 per kg. Also, and then you convert it. Also, we use that one, and another one. Those are the main drug components that I use during the CPB. The other drugs at our center, the other drugs are given by the anesthesia. Also, you find we use phenyl, which is a vasoconstrictor, and you find we'll give around between 100 to between 100 to 200. Between 100 to 200. We don't exceed that. So the drugs that we use during the CPB, that is sodium bicarbonate. There's mannitol and the phenyl when you're working on your pressure. Yeah. But I believe I also there's magnesium sulfate.
Yeah.
There's magnesium sulfate that is 30 milligram per kg. After the when you're about the cross clamp is after about the cross clamp is coming off, and also there's calcium chloride, which is 10 mils per kg. Yeah.
Okay, so I would like to ask you a question. Do you
Yes.
add any drugs in the priming solution?
Yeah, we do. The
Yeah.
drugs that we add in the prime include the sodium bicarbonate and
So how much do you add for the pediatrics?
pediatrics. At the pediatrics, I add 10.
Okay.
I do 10. 10 mils, and then also there is another. But at our center, we're trying to get away from using mannitol because there's a study that showed it's not that important, but it's still under discussion about using mannitol in the prime. Okay, yeah.
So do you add FFP,
We don't
fresh
add FFPs.
fresh frozen plasma in the prime?
We don't add FFPs. We don't add FFPs at our center. We don't add. But there's. I was discussing with someone in US. He was saying in the center they use FFPs in prime, but for us we don't. We don't use FFPs. Yeah.
Okay, and what about the blood priming strategies, like for pediatrics usually?
So the blood priming strategy. Number one, you need to treat that blood. Okay, so you'll add. Remember, this blood doesn't have calcium in it. Okay, and also this blood it has high potassium. For example, you might not have that fresh blood, so you'll find most of the centers they have blood that has old blood. It has stayed for some time. So this blood is it has high concentration of potassium. So you need to wash it. Let me use that term. First, you wash the blood. So you use I'll use normal saline, and then after that I'll add calcium because it doesn't have calcium because of the citrate which binds to calcium. So I add the calcium, and then I do the blood gas. So after doing the blood gas, I need to have potassium level and the calcium level at the same. The electrolytes need to be to balance the normal blood electrolytes and the blood prime electrolytes. If it's not balanced, again I keep on treating it until it is balanced. That's when now I can proceed with the CPB. Yeah.
Okay, thank you. So we'll go to the next question.
Okay. May I obtain the components of the lidocardioplagia at your institution? So the components of the lido we have number one is the lignocaine, and you need to understand there are two lignocaine. There's that of 1% and there's 2%. So there's lignocaine and there's magnesium sulfate and there's potassium chloride and there's sodium bicarbonate, and lastly there is mannitol. Yeah. So those are the components, and then now we have the crystal which is ringas lactate. That's what we use.
So what is the amount, like how much dosage do you give in pediatrics for Delnido? Means how much drugs do you add?
So
Because in adults we know the dosage is fixed, but in pediatrics do you change the dose according to the weight, or you give the standard Delnido dosage?
we give standard the needle dosage. You just prepare as a liter, and then we're just going to give 20 per kg. That's what we
Okay, so
give.
what is the total dose?
The total dose we do 20 mils per kg for the cardioplegia dosage.
Okay,
So, for example,
and
if
how much potassium do you add?
potassium it's a 16 in 1 liter. In 1 liter of ringas lactate, you add potassium 16 mils. Yeah.
Okay, so all for all pediatric cases you give 1 liter of Delnido cardioplegia.
So now we make 1 liter
Okay,
of the needle cardioplagia, right? And then in that 1 liter, now we give
as per 20 ml per kg.
the required dosage. Yes. Yeah.
Okay. So we have one more question from Sai Kumar.
Okay.
Explain about venting in pediatrics.
Venting. Venting
So
is
what are the venting strategies, like aortic root vent and other ventings for different cases?
so for the for the venting, I think it's just the venting strategy that we use. I think it depends. It depends with the case. I think it depends. It depends with the case. And now there is that venting from the roots, uh, from the roots, and also there's venting from the pulmonary vein, and also there's that venting from the LV, where there's that direct part. So it depends. The venting strategy depends. It depends with the case. Yeah.
Okay, we have one more question. It's from Mansoor. What are the main causes of hemolysis in pediatrics?
Uh-huh. You can go to that slide kindly.
Yeah.
To slide number. To slide number 8. Number 8.
Yeah, it's 8. I think it's not the 8th slide.
Go to hemostasis.
Okay.
Uh-huh. Just ahead. Behind. Yeah, I think. Anyway, let me just talk to the. So the question is causes of
Hemolysis.
hemolysis. So,
Hemolysis.
oh, sour. So, sorry, I read hemostasis. I'm very sorry for that. So, hemolysis, you'll find ways that some of the things that can lead to hemolysis. Number one is the over occlusion can lead to hemolysis. Another thing is about your suckers. When those are two things that can really lead to hemolysis. When your suckers, you use your suckers, your suckers are very high. For example, you're flowing at a liter. Okay, remember it will lead to breakdown of the red blood cells, and at the end you'll find that you're having hemolysis. So I'll maintain on the two. Maybe you might have another one, but the main causes you find is having high suckers, and also when you have over occlude your main pump. Yeah, those are two things I can talk on the hemolysis. Yeah.
Okay, we have one more question.
So
When?
went
Yeah.
on,
Yeah.
went on CPB with 500. I think it's the ACT, right?
ACT. Yeah.
And then almost 4 hours of CPB. My ACT is around 400 to 500, almost all the time. Should I give additional dose every hour? Shouldn't I add? One thing we use, one thing we at the center we really maintain our ACT to be above 480, and you find at some point, as you have said, you've gone and then your ACT has gone down to around 400. Remember, your target is 480. Okay, your target is 480. So you need to, I will add. You need to add, so that you need to maintain your ACT to around your ACT to above 480. So the answer is I should add. Yes.
Yeah, I think we should prefer maintaining the ACT around 500 to 600,
Okay.
because the minimum ACT we maintain is 480. So it should be between 500 to 600. That is the safe thing, I think, on
Yeah.
CPB.
Thank you. Yeah.
So we have one more question.
3 kg baby, full flow. How much as you calculation temperature is at 28? So remember, when you are cooling, there's reduced metabolism. Okay, so at 3 kg baby, full flow. How much as your calculation temperature at?
So what is the flow according to 28 degrees temperature for a 3 kg baby? What should be the flows?
Or full flow?
No, what should be the flows at 28 degrees for a
Okay.
3 kg baby?
So at 28 degrees,
Yeah.
remember there's decreased metabolism, and you're not supposed to be at the full flow. Okay, so you can't flow at an index of 3 at 28 degrees Celsius. So I'll go down to around an index of around 2.4 to around 2.2. Yeah, that's how I can use. Yeah.
Okay. We have one more question.
Neonatal cases, cyanotic. I think he meant cyanotic. how much the partial oxygen has to
Yeah.
be. So these patients, they have high. Remember, they have high hematocrit, right? And uh, and then the funny thing, the moment you've gone on CPB, uh, the hematocrit goes down. I don't know if you have encountered that, and you need to maintain your partial oxygen. On our center, we maintain between 150 to around 200. That's how we maintain our partial
Yeah.
partial oxygen. Yeah, that's how we maintain. We don't go high because of remember there's an issue with high oxygen, so we maintain between 150 to 200. That's how we do.
Okay. So we have one more question. What is the
Dosage.
dosage? Yeah. What is the dosage of albumin in priming in pediatric patients?
So for us, we do 25 to 50 mils, yeah, in priming.
So, is there any contraindications of drug dosage? Is there any contraindication for any drug?
Is there any contraindications of drug dosage? Maybe try to explain this question. I understand it.
So, the question is there any contraindications of drug dosage? That means, is there any contraindications, any side effects, or in some pediatric procedures, is there any drug which we need to avoid?
Oh, okay. Yeah, you need to. Calcium is very calcium. I'll talk about calcium. Calcium is
Yeah,
not. Calcium is. It can cause chaos when
yeah,
you give much calcium. So there's you need to really work on the dosage, the right dose for the calcium chloride. That's one. That's number one, and also. Uh, I think I've just encountered the calcium chloride. So you need to really don't just give calcium
yeah,
to the pediatrics. I think it's not the right. So you need to really ensure you're doing the right dosage. And mostly when there's you're doing priming. Yeah, remember we said when you're doing prime, you need to add calcium because already that blood doesn't have calcium. So give the right dosage. Yeah, that's what I
yeah.
can talk about.
That can cause blunder. I think in pediatrics we should calculate the dosage very precisely.
Yeah.
In adult, maybe like we can give some extra dose, but in pediatrics it should be accurate. So there is one more question about calcium in pediatric.
Uh-huh. The question
Should I
is
read? Should
about
I read the
about
question?
yeah. Kindly read it.
Should I read the question for you?
Yes, yes.
Okay, so the question is calcium. What is the importance of calcium in pediatric cases?
Okay. So there are two places we use calcium. Number one is during prime, when you are doing the blood prime, and also later after cross clamp, after cross clamp, and then you give calcium later. So there's that to increase after the cross clamp. There's that bit of increasing the contractility, right? That's the reason for giving calcium at that time. And remember, you can't give calcium when the cross clamp is on. I think you understand. You understand the reason for that. There's a time you mentioned in one of your posts in LinkedIn.
Yeah,
Uh, yeah, so you don't have to give calcium you don't. It's not good to give calcium when the cross clamp is on because of the stone heart. So the importance of giving calcium after the cross clamp, after the cross clamp is off, is to increase the contractility, and also this will help to increase the cardiac output. And the other place we use calcium is when you are doing the blood prime. That's the other part when you are using calcium. Remember, the blood that it is stored in the blood bank, it doesn't have calcium. The blood bank has there's a component, it's called sodium citrate. So this sodium citrate, it binds calcium. Okay, remember calcium is a clotting factor 4. Okay, so this citrate binds calcium. So this blood doesn't have calcium. So the reason we are putting calcium in blood prime, we need calcium. We need calcium in it. It's remember, when you're going on bypass with the blood that doesn't have calcium, you'll have issues with you'll have issues with your pressures. The pressures will be very low. So you need to have at least the calcium need to be at least 1 and above. So the two places we use calcium is number 1 during the blood prime, and number 2 during the off cross clamp, and that one is to increase the contractility and have a good cardiac output.
Yeah, calcium is good, but sometimes it may cause some side effects, because calcium overload, in many cases we have seen that due to calcium overload, the heart becomes stone heart.
Yeah.
So we should avoid calcium overload and overdosing in pediatrics. So the next question we have about using antibiotics during CPB.
Now at our center, some drugs were given it to the anesthesia team. So one of the drugs they do is the antibiotic, which we use the cefazolin, and they'll just prepare and they'll give us to administer it in the reservoir. But for us, we as a perfusionist, we are not supposed to do that at our center. Okay, but they give us to give to the patient where the case is going on.
Okay, so different centers have different protocols.
Yeah, exactly. Yeah.
In some centers, perfusionists give antibiotics on pump, because in my center I use antibiotics on cardiopulmonary bypass for all the patients. So it depends on the protocols of the particular center.
Yeah, it depends with the protocol. So our protocol, there's some things we have allowed the anesthesia to do, and there's some things we do it on the pump. But you'll find that there are some centers, you as a perfusionist, you do everything. For example, I will mention about the use of steroid. For us at our center, we don't use steroids. We don't use steroids during the case. But I understand there are some centers they use steroids, right? Yeah. So different centers, they have different way of doing that.
It depends on the protocols, even about the anesthesia drugs.
Yeah, exactly.
Yeah. So we have next question about whole blood or PRBC. Which is the best one?
So the whole blood, remember, whole blood has all components. Yeah. So, for example, the patient is having issues with bleeding, and this patient, you're going on bypass, and the patient has bled a lot. So this patient, you will need whole blood, because it has everything.
Yeah, all the clotting factors.
Yeah, it has all the clotting factors. There's platelets in it, So we'll go with the whole blood.
Yes. I personally prefer the whole blood.
Yeah, so for us,
I never use packed RBC.
We really prefer the whole blood in scenarios like this. But when you are talking about the packed RBCs, that is some time. Okay, yeah. So we just need to boost the hematocrit. Now we'll go to
Yeah.
the packed RBCs. But
I think
in
I
case,
think
yeah,
yeah, I think we can give the packed RBC post-op after uh,
yeah, even
the
post-op,
surgery.
yeah, even post-op after surgery, we
Yeah,
can do the,
but on CPB we should prefer whole blood.
yeah, sure.
So, do you have any experience in giving pulsatile flows in pediatrics?
Ah, we don't use pulsatile flow. We use non-pulsatile. Yeah, we use. I've never done that. Though there's some people that saying pulsatile flow, mostly in adults. They say it is good because it helps in how can I call it? It increases perfusion to the
Yeah,
organs well compared to
it mimics. Yeah, it mimics the
non-pulsatile flow.
natural circulation.
Yeah, but for us, we don't. I've never encountered the use of pulsatile flow. Yeah,
Okay. Okay, so it's the same question.
yeah, it's the same question.
We'll go to the next. Okay, so the question is perfusion strategy for sickling positive patients.
I think we need to have that session because it's totally different thing. Because remember, I think it's the question is about sickle cell, right?
Pardon?
The question is about sickle cell,
Yeah,
sickle cell.
sickle cell. Yeah,
Yeah, sickle cell patient. So perfusion strategy for sickling positive patients. Remember, these patients you can't. Wow, these patients you can't cool them, right?
yeah,
That's number one thing. They need to have the normothermia all
yeah,
through because the moment you cool, you have issues with the you have issues with the how can I call it the red blood cell. So uh, I think it's something that
yeah.
I need to work
And
on.
we
It's
should add. What about adding blood for these patients?
I've never encountered this case, but one thing I know with sickle cell as a perfusionist, you need to prepare yourself in terms of number one is the cooling,
Yeah,
also the oxygenation. You
oxygenation.
need you need it need to be high. Okay, yeah. So those are the two strategies that I can talk about.
Yeah.
About the blood, I'm not sure about that. Yeah.
So the next question is, what is the duration of muff, and how much fluid is removed in ml per kg?
So the duration of MAF, we do it at 10 minutes, uh, 10 minutes after the case.
Yeah,
And also it depends with the duration. For us, we do MAF every patient. We do MAF. We do MAF on every patient. So we do 10 mils per kg. Okay. So if you have 3 kg, at least you need to remove 30.
yeah,
Okay.
extra
So,
volume. Yeah,
yeah. So we work with 10 mils per kg. Yeah.
okay. So we have one more question, and which is better in pediatrics, pH stat or alpha stat?
It depends with the case.
Okay.
It depends. It depends with the case. Remember, I said with the pH stat is when you are doing deep circulatory arrest, uh, and then you need to allow blood to flow to the brain. So you need to do pH stat because remember when you're at alpha stat, when during deep circulatory arrest and you are doing alpha start, there will be reduced oxygen to the brain. Okay, so by using the pH start, there will be increased carbon dioxide, which dilates the vessel and increased blood flow to the brain. Okay, so and then this one will help in good perfusion to the brain. So it depends.
Yeah.
Okay, it depends with the case you're doing. The normal cases, these simple cases, SD closure, VSD closure, you just do alpha start. Okay.
Okay.
But in case you're doing these complex cases that need when you're doing these complex cases that need deep circulatory arrest, it's advised that you do a pH start at that moment.
Yeah.
But when we are starting to warm the patient, we go back to deep circulatory arrest, we do pH start. But when you are warming the patient back to normothermia, we're going to the alpha start.
Okay, so the next question is phenoxy dosage for severe pH cases.
Phenoxy, which drug is that? Let me.
So what is the strategy for severe pH cases?
Pardon the question?
For pediatric cases, severe PAH cases, pulmonary hypertension. If there is severe pulmonary hypertension, pulmonary artery hypertension.
Okay. So what are the
strategies you use for such cases?
Severe pulmonary.
Do you use any specific drug or any strategy?
We don't have a strategy for that. I've not have. I think that question I'll have to look at it. I'll have to look at it. Yeah.
So the drug is phenoxybenzamine. Yeah.
I'm trying to get, because this is a drug. It's a trade name, right?
Pardon?
I'm trying to get the name of that drug because it's not phenoxy. Because I think the person have used the trade name.
It's phenoxybenzamine. Benzamine. I think it is mostly used in pre-op.
Okay, I've not encountered that drug. I've not encountered that drug.
Okay, so we have one more question. So even if your ACT, even if your ACT is adequate,
heparin should be added. 90 minutes of CPB.
Yeah.
Otherwise, GIC might happen. So they say that even if your ACT is adequate, heparin should be added every 90 minutes of CPB. Otherwise, GIC might happen. So I think there's something that you said earlier that every centers have their own own way they're doing
different
things.
protocols.
Yeah, we have different protocols, and like this one doesn't. We don't do this. Yeah, so like remember we said like we need to maintain our ACT high.
Yeah.
You need to play safe. Remember your oxygenator.
It's very important.
Your oxygenator is very important. If you mess up with your ACT and your oxygenator fail, that's another issue. Okay.
Yeah.
So you need to have high. You need to have your ACT needs to be high all through. So I can't comment on this. It's
Yeah. I think the main thing is maintaining the ACT.
Yeah, you need to maintain your ACT.
Yeah, not just giving heparin after every 90 minutes, but if the ACT is less, we can give before 90 minutes or within 30 minutes also.
Sure.
If we notice that the ACT is not adequate.
Okay. Yeah.
Okay, so one more question we have: what's the glucose and lactate level to be maintained in CPB?
So your lactate, the lactate's not, no, it's not supposed to be above 2.
Yeah.
That is the, it's not supposed to be above 2. And then also the glucose, at least between 5 to 6. Yeah, that's okay with the glucose level. I think you need just to maintain. Remember, with bypass, it's just you're trying to maintain the normal physiology, uh, uh, the normal body physiology. Okay, so if you're maintaining the glucose level, the normal body physiology of the glucose between 4.5 to 7, or 6.5, and then you maintain your lactates, not above 2. I think you're good to go. Yeah.
Yeah, and what about the glucose level?
No, I'm saying the
RPS.
glucose we use. I don't know. I've said between 4.5 to 6. Yeah, that is how I can talk about the RBS.
Okay.
Oh, I think the values we have
It's
different
yeah, yeah,
values.
yeah, 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 yeah.
Yeah, different values. I've noted that. So between 4.5 to around 6.5 millimoles. Yeah.
So I think this session is going to go too long.
Well,
We have a lot of questions coming. I
oh
hope
my.
you are not in a hurry.
I'm not in a hurry. I'm not in a hurry.
Okay, so we have one more question. We'll try
Okay.
to finish it off a little faster.
Okay, let's try. Yeah, sure.
Yeah. So how much dose of heparin do you add in prime?
So those of heparin are between 3,000 to 4,000 international units in prime for the
Yeah.
pediatrics. Yeah,
So it's is the fixed dose you add
yeah, it's the fixed dose we add.
3,000 to 4,000.
Yeah, 3,000 to 4,000.
Okay. Okay. So how much dose of xylocaine after cross clamp do you need after cross clamp removal?
Oh, that is, I think the person is talking about lignocaine. This is a lignocaine,
Yeah,
right?
lignocaine. Yeah.
So for us, we don't use lignocaine. Uh, we do. I mentioned on the magnesium sulfate. That's what we
Okay.
that's what we do with our protocol. Yeah. I don't know. Maybe you can. You've done this. Maybe you can.
Yeah, some centers use. I think maybe you have a different protocol, but I use this Xylocard after
Okay.
we release the clamp.
Okay.
Yeah, it is to stabilize the myocardium.
Okay.
If there is any heart block, or so we'll go to the next. Is it safe to use St. Thomas for ASD cases in pediatrics?
Uh, so so we have different these the cardioplagia that are different. You have the Del Nido, you have the St.
Yeah,
Thomas, we have this custodial, right?
yeah.
And
So
not
apart from Danido,
okay.
do you use St. Thomas?
Yeah, there's some centers they use St. Thomas.
Okay, so for
Just
which cases do you use St. Thomas?
St. Thomas, they do all the cases, but you'll find mostly in pediatrics, they prefer Del Nido. Okay.
Okay,
They
so for ASD and VSD also?
Yeah, I can't comment on that because all the cases I've done, I've been using Del Nido.
Okay, okay.
Okay, yeah,
So
I
I
can.
personally, yeah. So I personally use St. Thomas for ASD cases, all the ASD cases.
And the reason for that, maybe you can share the
The
reason.
reason is just to save the time. I think we need Del Nido for a long procedure,
Yeah,
and
yeah,
Saint
because
Thomas.
between 60 to
Yeah,
90. Yeah.
yeah, and Saint Thomas is good for a short procedure.
Oh, yeah. Okay, okay, okay,
So that is the reason.
okay, okay.
So how much urine output to be maintained for ensuring optimal kidney function?
So the urine is, you find it's between zero point 0.5 to 1 mil per kg per hour. So you need to maintain that during the case.
Okay. So we have the same question: perfusion strategy for severe pH. So I think you answered this before.
Okay.
You don't have any particular strategy for severe
Yeah.
pH patients.
Yeah.
Some centers have strategies, but
Okay.
these strategies are very common. Like we need to use filters,
Okay.
and the urine output should be adequate.
Okay.
Urine output should be good,
Okay.
and the
So,
filtration is necessary.
so
Filtration,
you wait. You said about hemofiltration,
yeah, hemofiltration.
and then also you need to have adequate urine.
Yeah. So my personal strategy, which I use for severe pH patients, is I do hemofiltration for all the severe pH patients,
Okay.
and also I do retropriming. I reduce the priming volume. I remove the
Okay.
extra fluid from the circuit. I maintain minimum fluid, and I prime the circuit with blood.
Okay. Oh, okay. Okay.
Yeah. So I think we have answered this question before.
Yeah, just to tell, if the patient is anemic and you need to do the calculation of post bypass hematocrit, and
Yeah.
if it is less, you do blood prime. You prime your circuit blood, and then yeah.
So we have one more question: how much reversal protamine is given in pediatric cases?
Uh-huh. Okay. So the reversal, I think I don't know if you have encountered it, but we just do the same way with adults.
Yeah, same. Same. Yeah, the protamine dose is 1:1.
Yeah, 1:1.
I
We
guess
just
it's the same in your center.
yeah, just do the same way we reverse with
Yeah,
the same way we reverse
yeah,
the way we reverse adult is the way we reverse
yeah,
the
and mostly it's given by the anesthetist.
yeah, and that is the work of
So
anesthetist,
we
not
need
for us.
not to worry about the protamine.
Yeah, exactly.
They look after it. So we have one more question: what are the drugs which cannot be used in pediatrics, which have severe side effects? So what are the drugs we need to avoid in pediatrics, which
So
we can use in adult, but we should not use in pediatrics,
so the drugs that can be used in adults,
but we should avoid in pediatrics?
we need to avoid in pediatrics. Um, uh, I'm trying to I'm trying to think.
I
Uh,
would say that
do you have maybe you can just
no, I have like I commonly use
because
all the drugs
because
which I
we
use
use
in
all the
adult,
drugs. Yeah, we use all the
but
drugs.
yeah, but I would say that I personally avoid normal saline priming.
Oh, normal saline. Yeah,
So
we don't.
yeah, apart
You,
yeah apart from drugs, we should not use normal saline in pediatrics.
yeah, even priming with. Remember
Yeah,
in the slide they talk about hypocholeremic acidosis. Uh, so using in that's why you don't even prime with normal saline. You don't prime circuit with normal
yeah.
saline. Yeah. Yep. Now, what if you do? Okay, maybe I think someone might ask why. Maybe, for example, this patient is having low sodium. If you can add sodium chloride, normal saline, in the circuit. What can you talk about that?
Pardon? I didn't get your question.
So you're having low sodium during the case, okay?
Yeah.
So will you opt on using sodium bicarbonate, or maybe you can put some saline in your
Yeah,
pump?
I'll use half NS.
Or you lose half normal saline. Okay.
There is a solution that is
Yes.
it contains half sodium. I think this there are two solution two fluids.
Okay.
Yeah, one is the full normal saline and the other is half normal saline.
Okay. Okay. I think you're done.
So we are at the end and we have just two more questions.
So
So can
let's
you tell? Yeah,
only two questions, right? So
yeah,
can you tell us about cannula selection for pediatrics? So I'll discuss how the way our protocol, because I understand we have different ways people do cannula selection. There are some people they based on their weight, but we use flows. Okay, so for us we calculate the flow of the patient. Okay, so if you're having a flow of we calculate the maximum flow. And with the maximum flow, we're able to calculate the cannula, the arterial cannula and the venous cannula that we are going to use. I understand some centers they go with the weight of the patient. Okay, so I don't know if I'm right on that.
yeah, yeah.
Yeah, but for us, the cannula selection for pediatrics, we calculate with the flows. So I
Yes,
calculate the maximum flow, for example, the cardiac index of 3. At 3, these patients will be able to flow with around, let's say, 500 or 400 mils per minute. Okay, so with that, I'm able to get the if I'm going to use the 14 French or the 12 French aortic. Yeah, so that's how we do our cannula selection. Yeah.
okay. So the last question we have.
Hot shot, yeah, we do. We give hot shots. We,
Yeah.
we give hot shot dosage. Yeah.
So what were like how much dose do you give? How much hot
Um,
shot do you give?
I can go about 10, just 10 mils per kg.
Okay.
Yeah.
Okay, we have one more question and we'll finish off.
The last one,
What?
right?
Yeah, last one. People are very much interested in this session. I think we had a lot of questions today.
So what's special? Perfusion strategy. Wow. Okay. Arterial switch operation surgery.
Yeah, arterial switch surgery.
Wow. This
Is there
these
any
are
special strategy you use in arterial switch?
so remember with I think here there's bit of uh, antegrade cerebral perfusion. I think in this case, though I've never encountered this case.
Okay.
I've never encountered this case. So I'm not been in a position to fully answer the question, but I
I
believe there's
think
been. Yeah. Have you ever
uh,
encountered this case before?
yeah, I think there is like uh, I would say for in the case of special strategy, we should prefer goal directed perfusion as we were discussing today
Okay.
in the morning.
Oh yeah. Okay.
Yeah. So in such cases, the goal directed perfusion is important.
Okay. So maybe you can just go through the maybe
Yeah.
to answer the person the way you have you're telling us in the morning.
I think this session is we'll have a special session again for this.
Okay.
I think it's because the questions are still we are getting few questions.
That's
I hope
enough.
you don't mind.
Ah,
So if you are fine, we have one more question?
only one, and then we finish. Okay.
Yeah, yeah. So
So some
yeah, you can.
diagnosed patients, same diagnosed patient, same weight, both are cyanotic, same oxygenator, but for one patient during rewarming, it's it's desaturating, and one more is normal. How that's possible? Let me repeat the question. Same diagnosed patients, same weight, both are cyanotic, right? Same
Yeah,
oxygenator, but for one patient during rewarming, it's desaturating, and one more is normal. So I think I can answer like this. You know, when you are rewarming the patient, there's increased metabolism, right? I don't. The other patient, I don't know the FiO2. It's how much. Remember when the bypass is on, maybe you can bring your FiO2 to around 70, right? Not 100. So at that moment, you're cooling this patient. There's no increased metabolism, so you'll find the patient is not desaturating. I don't know if I'm right. I'm answering this question. So you find if you are rewarming this patient and still your FiO2 is not, you have not increased your FiO2 to 100 because you need you need more oxygen. I think you'll find this patient is desaturating, and you might feel like there's an issue with the oxygenator.
yeah,
But you need to check on your FiO2. When you're rewarming the patient, your FiO2 needs to be at 100%, not at 70 or 50.
yeah.
It needs to be
And
100%. Yeah.
even if the FiO2 is at 100%, and still if the patient is desaturating, so
So
um,
now you need to check. Now, is it? You need to check how is your
you
ACT.
need.
Now let's go down. How is your ACT?
Yeah,
Is your ACT come down to 300?
yeah,
Okay, and also we need to know there is blood path and there is how can I put it? That blood path? Is it a problem? There's clot. Is it forming in the oxygenator or not? So, or is it you're having an issue with your
oxygenator.
oxygenator line or yeah? So there are some things you need to consider. So when you are rewarming the patient, your FO2 need to be 100%. If it's
Yeah,
100 and still you're finding there's desaturation, now you need to check. Hey, how is my ACT? Is my
yeah. There
ACT
may, yeah,
is
there may be
it?
some technical issues, or there may be
Yeah,
maybe some surgical issues also.
yeah, exactly.
Yeah, so I think it's a teamwork. So the surgeon also should check the procedure again, I think,
Okay.
or we need to check the oxygenator from our side.
Hmm.
Maybe it can be a surgical uh, issue.
Also, you might find it might be also your oxygen line. It's having a
Yeah,
problem. So
yeah,
before you come to conclusion that your oxygenator is the one with the problem, you need to, is the line okay? Is the gas line okay?
yeah.
Right?
Yeah, there may be some blockages or some
Yeah,
kinks or disconnection.
yeah, there may be a problem with the gas line. So
Yeah,
there's an issue with the gas line. That's number one.
yeah. There
The-
are, yeah. Okay, so I think we had a lot of questions, and
Thank you. I
we
think we're
had a,
done.
yeah, we
Thank
had a
you. Thank you.
wonderful session.
Thank you so
And
much.
I once again thank you for your wonderful presentation and explanation. And I hope all our viewers enjoyed this session, and you have wonderfully explained all the questions and cleared all the doubts. So
Yeah.
I thank you once again, and hope we see you soon with another topic on the live session,
Yeah, it
and
is.
wish you all the best.
It was an interesting topic, and also the questions were very interesting.
Yeah,
Some were quite challenging, but also we were able to brainstorm together and be able to answer the questions. Yeah, and also I like the fact that the question were coming at
Yeah.
the real case questions, right? Things that you
Yes. Yes.
find when you're running cases, and that's very
Yeah.
important. I want to thank you
But
for
you have wonderfully explained all the questions.
thank
Yeah.
you, sir. Thank you.
Okay.
Yeah,
So we'll see you soon again, and wish you all the best. And
thank
thank you
you.
guys for joining. And
Yeah,
see you soon in the next session. We'll be back with new topics. And if you have any suggestions, or if you need any uh, special topic to be discussed on the live stream, you can directly DM us on Instagram, or you can WhatsApp and share your comments, thoughts, and all the best. And see you all soon. Thank you.
thank you so much.
Thank you.
Bye.
Bye bye. See you.
Okay.